Our next speaker is going to be Dr. Fermin Garcia for Ben, and he's going to talk to us about parahisian VT. Fermin.
Thank you, Andre. Thank you, Frank, Dave, Vivek, for the honor to be here. I'm going to discuss ablation of parahisian VT. To be honest, when Dave and Frank asked me to do this, all that comes, and eventually what we learn over the years of this, is the original thought of these pictures. Focal arrhythmia, PVC or VT, that when you map the earliest site, it's right next to the His conduction system. You have a big His in sinus rhythm. And the common pictures are these pictures of fluoroscopy, in which you have a His catheter with your ablation catheter a little bit higher than the His catheter, or a little bit lower, and that's the successful site of ablation. So I think to redefine this and really understand what we need to do, like Pascual just greatly talked about LV summits, we need to understand the anatomy of where these arrhythmias come from, because they're focal arrhythmias. Although they can be disease processes that affect these areas, we're talking about focal arrhythmias. So the lesson learned from a lot of the studies published is that this is not a particular, a specific focal arrhythmia that comes from the His or in the His Purkinje network. Rather, this is some sort of arrhythmia that has a close anatomical relationship to other sites, because they're similar to things that come from the RVOT, at least in the electrocardiogram. And the teaching was, well, find the early spot. If you're right on top of the His, move away a little bit. 5 millimeters up, 5 millimeters down, a little bit forward. And usually you prevent heart block, but you ended with a right bundle branch block, or you were unsuccessful. And the reason is because we were being very careful to apply energy, because as you will see, this could be dangerous. And perhaps it's poor catheter contact. Some people have seen electrograms that are highly fractionated in this area in comparison with RVOT arrhythmias. They're absent. And I think this is important. If you map other places, and in some papers they did that, you see a far-field electrogram that's earliest on the sharp His potential. We suggest that it may not be coming from the His, but from somewhere else. And when you look at the unipolar electrograms on these studies, it was a slope that was not very fast, suggesting that you were not at the right place where you needed to ablate, or perhaps at the focal origin of the arrhythmia. Pace map here doesn't really work, so when we're going to talk about this, I think we need to focus on activation maps. So it's very important that the patient comes to the lab with arrhythmia. And this, I think, opened the eyes for me for anatomy in this region. In most of these papers, initial application did not suppress the PVC, but it changed the QRS morphology, which means to me that we're changing the exit, which means we're not on the perfect spot of the origin of the focal arrhythmia. So when we talk about parahisian, we need to understand what we're talking about. And the key concept here is membranous ventricular septum. And what is the membranous ventricular septum? It's this translucent piece of membranous tissue that you can transilluminate from the left ventricle, and you see it on the right ventricle. And it's this area between the right and the left coronary cusp. Importantly, and it has a lot of implication for the ablation, this area is covered by the septal leaflet of the tricuspid valve. So keep that in mind when we talk about the strategy to ablate these arrhythmias. It's attached to the aortic annulus in the same area of the right coronary cusp and the non-coronary cusp. So when you see the right coronary cusp and the non-coronary cusp, this is the membranous septum, this is the LV, this is part of the LV ostium. This is the most septal posterior aspect of the LV ostium. And importantly, as we will see in a second, you're right next to the conduction system. That's why we get a nice His. It extends obliquely down to the left side, and this picture is very nice because this is the membranous septum, this is the septal leaflet, this is a muscular ventricular septum, and you can see that it extends down to the left side, it extends down to the right side, and it's the attachment point for the tricuspid valve, and it has a space that essentially communicates right atrium with left ventricle. This is important also to understand. The septal leaflet is there. The left side is the part of the LVOT, and the right side is the bottom of the tricuspid valve. So I just put this in because I think it's a beautiful picture to understand what we're doing. This is the membranous septum and the muscular septum. This is the area we're talking about for these arrhythmias. The problem is it has a lot of neighbors. There is a membranous septum in yellow, that is the ventricular aspect, the aortic, the arterial aspect, and the septal leaflet right in between. We already said that. But the problem that we have is that the conduction system runs through it. So if you're mapping here, you get a parahisian PVC, but what's happening behind is what's important. I think it's, no matter what I say today, how can we approach these cases? We have to be very careful because this is the histology of this piece of tissue. The lower aspect of the membranous septum is where the His bundle is, the AB bundle, the His, not the AV node, the AB bundle. It has a quadrangular shape. It's in the bottom of this space is the muscular septum. And right there, you have the left bundle branch opens up to the left, and the right bundle branch opens up to the right. And this is our problem. EKG recognition, I think, is very typical, but you have to take it with a grain of salt. These PVCs or focal VTs are going extremely positive in lead 1. There's nothing that I've seen in EKGs that's more positive than this. You usually have a QS in V1 with a variable transition. It could transition in V2, could transition in V4. And I think characteristically, because of the location of lower relationship in the right coronary cos area and the top of the septum, it's less positive in 3 than in 2 because it goes more towards the right foot than towards the left foot. And characteristically, a difference of other arrhythmias I'll show you, they have a positive deflection in AVL and negative deflection in AVR. When you compare these arrhythmias, and you will understand why this happens, to typical posterior RVOT PVC, for example, they're very similar in certain ways. The difference, obviously, one is more narrow than the other, and what I said about AVL, but besides that, they follow a similar rule. And there is a simple explanation for that. In fact, these are 3 different patients. I ablated from the top of the RVOT, one from the coronary cusp, the other one for the top of the tricuspid valve. These are all similar morphologies when you describe it, although obviously when you look at it closely, you can try to figure out where they're coming from, but you have to map this area. And I think all comes down to this picture, and I think this picture is fantastic. And I'll drive you through it for a second. This is a cut histologically of the anatomy of the heart, for that matter. This is the right atrium, this is the tricuspid valve, this is the right ventricle, this is the pulmonic valve. This is the RVOT. When we say RVOT, we're too high. We're talking something lower than that. Right on the center is the aorta and the cusp. The arrhythmias that we're talking about today, the focal origin is from this tissue. This tissue right here, which is the septum. It's the posterior septum of the left ventricle. And when we go to map this, and you put a catheter when you just come from the right ventricle and clock it, you're on top of the His. You get that His potential. But what we need to think is the catheter move forward. Obviously, it's later because now you're in the RVOT. But how do we map this? And the approach that we will describe, instead of just burning there before you decide where you're going to burn, is you have to map behind the tricuspid valve this tissue. You have to map from the other sides, right coronary cusp, non-coronary cusp, and sometimes even from the right atrium. And if you approach this in detailed activation map from all these areas, you will have to tailor your approach to the ablation. How do we do this? Well, I think very important to understand intracardiac echo in this. This is from the right atrium. You can look perfectly this area, and you have the right and the non-cos. But not only to understand the anatomy, but to understand the obstacles. This is a patient with a parahisian PVC. If I look at this image of echo, I understand right now, and you will walk out of here understanding what are your obstacles. This thing here, the Eustachian ridge, very variable in very patient. This is your first stop sign to get into the right atrium. If you have a huge Eustachian ridge, you cannot do anything in good contact in this area. And your second obstacle is the tricuspid valve. So you need to overcome these 2 natural existing structures before you can map this area. And how do you do that? Well, you have to do this with some sort of long sheath to get support, because if not, your catheter goes to the right atrium. And if you use a steroid sheath, for example, in this particular patient, just like we do for CTI when you have a big Eustachian ridge, you move the Eustachian ridge down so you can get into the right ventricle. And then in order to be behind the tricuspid valve, you cannot just push the tricuspid valve and pretend you're going to get it over. You have to put it behind the tricuspid valve. So you have to have this second curve. This is beautifully nice. You know exactly where you are. This is how it will look in fluoroscopy. I think you have two options, but I would rather take this one. And then obviously you can open your catheter in order to have good contact, and that's what this bottom picture now shows. You can open the catheter, open the gilus up and down, and then you have very good contact. With this image, I will summarize what I'm trying to say. And I have here an anatomical character reconstruction of the right ventricle, the cos, and the left ventricle. I have here that histologic thing, that cut that I showed you before, and I have here a nice picture from the right atrium. And I have here the activation for this particular patient. So the first thing we did is we say, all right, let's map, it looks parahisian. And if you only look at this Hisian signal, it's very sharp. You clearly have a His and a retrograde His, and it's pre-QRS. And this is where we are in eyes. I'm sorry, in the map. This is where we are in eyes. And this is where I think I am in that histological picture in my mind. So now I said, all right, this doesn't look good. I don't want to burn here. Do I go forward or lift up 5 millimeters and see what happens? Maybe right bundle, who cares, right? I don't think we should do this. I think we should go and map the opposite sides. This is the right coronary cos. This is the activation time at the same time, so you can compare the 3 anatomical sites in the same slide. And if we are a little bit behind between almost the right non-left junction, you can see here it's what I said before, a far field signal, but it's earlier than the His signal. And if I go behind the tricuspid valve right here with that curve that I showed you, which would be right here in this histological, it's even earlier. And there's no His. This is an A. This is not a His. This is with the P wave. You can see this continuous. So I think what we need to do here, instead of just getting here and say, all right, it looks good, let's try and see what happens, we need to do detailed mapping around this area and put it all in perspective and see which is the early site. Because clearly here, you get away from the His, and you don't even need to ablate there. You just need to understand the anatomy. And obviously, there's one spot left, and this is a case that was kind of early on the right side, but not dramatically early, had failed an ablation before with fear of heart block, came to me. This is the activation in the right coronary cos, non-coronary cos. You can see the His there because the membranous His, the membranous septum also have a left side, as we said. And this is right below the non-coronary cos in this tissue. And that was very early. However, it was the best we had. And we apply energy here, the PVC would go away and would come back, would go and come back. And just the concept that I explained before is what are your neighbors, what are the neighbor structures to ablate this area. We saw in intracardiac echo a neighbor structure, but it didn't make sense, right? That's the right atrium. Well, we just put the catheter there, follow an intracardiac echo, and place right opposite where we were ablated. And this is a learning point, because if you see this septum, we did a lot of ablation with irrigated RF, trying to get rid of the PVC and kept coming back. Look how swollen this tissue is. It would not happen today because I learned I have to map in different aspects. When we put the catheter here, this is the activation. It's way early with a very nice unipolar, a decent pace map, but we already know we don't use pace map in this area. And ablation here eliminated that PVC with our heart block. So the understanding of where we were came from looking at anatomy again. This is in top the eyes picture of the catheter in the left ventricle, and the bottom the eyes picture of the catheter in the right atrium. This is what we're doing in this case. This is the membranous septum in yellow on the top. This catheter below a non-coronary cos, it's in the opposite aspect, most proximal aspect of the posterior aspect of the ventricle, called the posterior superior process of the LV. This yellow thing is the membranous septum. If I put the catheter in the right atrium, I'm mapping the same space, because it turns out if you put the right atrium in there, it covers the posterior superior aspect of the left ventricle. So you can map the left ventricle from the right atrium, and we know that. And it's not that it's in every patient, but it's another point of mapping anatomically when you do this. This is an anatomical cut. This is the non-coronary cos. This is non-coronary cup on eyes. This is the CS. We're not in the CS. We're right outside of the CS in this atrial tissue that covers this most posterior aspect of this ventricular septum. Obviously, everything has a price. You have to be careful. The AV nodal artery runs through here in the pyramidal space. So theoretically speaking, without damaging the AV node, you could get heart block. In our experience of 6 patients now that have required mapping in this area, we haven't had a problem, but I think it's something to keep in mind. Finally, I want to bring a point of RF versus cryo. And I think there's some utility to this. If you're worried about causing a problem, again, my fear of cryo is the manipulation of the catheter because it's very difficult, but if it's a straight point, this is a patient that came for ablation, had failed procedure before. You can see there's a longer PR with a right bundle branch block already, and the PVC was still there. And this is why I think we need to map very carefully, because if you already damage something, and the PVC goes away and it's just a right bundle RI, well, that's what it is. But what if we keep damaging conduction system and the PVC doesn't go away because it was obviously not coming from there? In this case, I used cryo. Again, this is another case of that aspect of the right atrium, simply because I didn't know what was going to happen and there was already some underlying damaged conduction tissue. So, in conclusion, I think that these parahisian arrhythmias really represent ventricular focal arrhythmias. And you can apply these concepts to septal substrate VT. It's the same thing. It's the same area. It's the same way of mapping. And they look parahisian when we walk in the right ventricle because we're simply next to the His, and there is a very rapid conduction to the conduction system in a small area with a very fast transeptal activation time. So that's what you're getting, but that's not where it's coming from. The EKG R in 1, QS and V1, positive AVL, narrow QRS, tends to distinguish this from RVOT PVCs or VT, but keep in mind that you still have to do detailed mapping. And you get similar activation time at different related vantage points that you need to use in your advantage to find the best one. And sometimes, if the PVC doesn't go away from that one, ablate from the other one, and usually there are minor changes in the EKG as you go. I believe ICE is an essential tool for this, to understand the anatomy and to guide the mapping just like it is for other areas. A long sheath helps contact and it helps you to overcome the anatomical limitations. And I think let me rephrase that, do resist the temptation of walking in and an initial early site that looks really good next to the His and move a little bit up before you map the other sites, because it may not work and you end with right bundle branch block. I think you may need, finally, ablation on more than one site, but you need to choose the neighbor, and that's why anatomical reconstruction is very important, because you will know what's opposite in that particular patient. And this, always, we're ablating, we have a 12-lead EKG in the Pruka running, because you need to pick up minor changes in the QRS. And for some patients, cryoablation could be useful, and things especially for contact, or those patients who already have had multiple procedures, and you have a higher worry that you will cause heart block. Thank you very much.
Thank you, Fermin.